The topic for today is pediatric ACL reconstruction. So we'll talk about its uniqueness and things like that. That said, there are some guys who don't believe in doing any special techniques for pediatric patients. They just do the regular adult techniques, and some studies have come out that show that that works equally well. But we'll talk about, if you do want to do physis sparing techniques, what are our options. So the incidence is definitely on the rise, and that's why there are many articles published recently about pediatric ACL tears than it were in the last decade or so. One of the reasons is that we see more and more of these. Traditionally, we used to be like, all right, you tore your ACL, don't play sports for the next 6 or 8 years. See me back in 6 or 8 years, and we'll kind of fix your ACL then. So that was a traditional approach. Even now, some orthopedic surgeons in the community would tell the parents that and the family that you don't have to get it fixed for now, just avoid playing sports. So the anatomy of the ACL, that's right from childhood, it's the same, two bundles. It's, we know that obviously in a child it's much smaller footprints, and we really don't do any double bundle techniques in kids. It's just a single bundle anatomic footprint. Here again you can see the footprint. That's the principles remain the same, and the reason I'm emphasizing on this footprint here is, and we'll come to certain techniques you can do in kids where you go through the growth plate, but then you have to drill a vertical tunnel, and then we have come a long way from doing vertical tunnels, and now you're like, okay, now we need to do horizontal tunnels. So if you try to do this kind of horizontal tunnel, look where the footprint is, then you'll end up going straight through the physis and scraping a lot of the physis. So it's a balance between transphyseal, where we go vertical, which is non-anatomical, versus you go complete physis sparing, so you don't get the physis at all. So there's nothing in between. You can't be like true anatomical and then not damage the physis kind of thing. So so there are different case scenarios. I do get it when there are some orthopedic surgeons say, when I really don't have to worry about the physis, I'm just going to go through the growth plate and that's fine. None of our patients had any problems. Well, that depends. I mean, if it's a late adolescent, then yes, the growth plate is almost closing and you don't have to worry about it, as opposed to someone like this who's I do have a patient who's very similar to kind of this. He's a 12-year-old and has an ACL tear, and we reconstructed it around 2 years ago. And all he is interested in doing this dirt bike, and parents are okay with it. And even after the ACL reconstruction, he has gone back to doing dirt biking. So, in a young patient like this who's so prone to tearing the ACL, do you really want him to function without his ACL? So the picture on the left is a younger patient with wide open growth plates, and the picture on the right is an almost closed growth plate, and obviously you don't have to worry about the growth plate on the right side. So when you see someone young and then you want to kind of determine how much growth is remaining, first of all, if you're contemplating surgical options, and obviously we'll talk about non-surgical options, but this is kind of a preliminary investigation. When the patient shows up in the clinic, you want to kind of know how much growth is remaining if you have an ACL tear. I do get skeletal bone age, hand x-rays to look for bone age in those gray areas where the growth plates are still open but the patient is not super young, where you want to know what you want to do in terms of ACL reconstruction. Now, can you predict skeletal age with MRI? I thought about it and then looked at the literature. There's just one study, not from any great journal, so I didn't pay too much attention to it, but it's interesting. Someone should probably do a study, and then you don't have to do all these kind of measurements, so it would be interesting. And then in general, this question kind of is asked in different ways for OIT and boards, and how much distal femoral growth is can you expect per year. These are just approximate numbers, but for every patient it's different. You have to kind of plot a chart, and that's the most accurate kind of way. If you have 2 points in time, then you can use all those formulas, you can use all those apps on your phone, but it's better to have 2 points in time to get a fairly accurate estimate. So So this is part of your evaluation, see how much growth is remaining. So what's the bottom line? So if we know that if there's a leg length discrepancy of more than 1.5 to 2 inch, then it can be symptomatic, right? So if the leg length discrepancy is more than say 3 centimeters, about an inch, then you're worried, you don't like that. So that would be your bottom line. If the child has more than 3 to 4 centimeters of growth remaining, more than an inch growth remaining, then you want to try and save that growth plate. So that's all to it. So if it is like, well, just has a centimeter of growth remaining, you don't have to worry about the growth plate, you can just go through it. Obviously, when a child presents with a knee injury, you do the usual. Don't forget about all those things you do. Draw test is not very sensitive, it is specific, so you have a significant translation with 90 degrees of flexion, it's most like an ACL tear. That said, most of them are negative in the clinic. Ligament is slightly more sensitive, and then remember the criteria for that. Okay, so what's the next step? You have this child, you're suspecting the ACL tear, you kind of roughly estimate how much leg length discrepancy is going to be. Then you talk to the family about what's the next line of management. If the child has a meniscus tear, then it becomes probably obvious that the child needs surgery. But if it's just an isolated ACL tear, you need to talk to them about different things. I had a few kids who were really not into sports. They did it while they were just trying out something. I had an 10-year-old first day trying for football or something. He put on his helmet and he was just fooling around. He tore his ACL. So he's not really an athlete kind of thing. But that's, you need to have a discussion with them. Like, can you wait another few years, 3 years, 4 years? The risk of growth plate injury kind of goes down with ACL reconstruction as they get older. So that's obvious. So do you want to wait a few years? Do you want to just get it done and talk to them about physiotherapy, brace, and obviously with the brace, the compliance is very, very important. So again, we are talking more and more about this because there are a lot more kids who are coming to the ED with this kind of problems. If you see Segon fracture, it's kind of probably an ACL tear if you see that. Again, this is a Segon fracture. You go in there and look at that. Oops. So how are kids different? These by definition, if they're active in sports, they're like any pro athlete or even more, because they are going to play every day relentlessly all through the year, the sports that they like, as opposed to a 32-year-old professional, for example, who's going to play maybe once a month. So they're extremely active. Compliance is an issue. I have several cases. They show up in the clinic 1 week after surgery with no brace, and they're walking on it and all those things. So compliance is always an issue. What do you tell parents? Does ACL tear mean maybe 20 years from now, if you don't do anything, will it lead to osteoarthritis? That was kind of our theory, and a lot of studies were done which do show an increase in these inflammatory markers, and it wouldn't be wrong to kind of postulate that, but there are no clinical studies that show if you have an isolated ACL tear, it's a risk factor, an isolated risk factor for osteoarthritis. Now, if it is associated with some meniscus tear or a cartilage tear, that's different. But if it's just an isolated ACL tear, so some studies to kind of give you the background, and to kind of talk to the families about what happens if we don't do these ACL reconstruction in these young kids. Most of them do end up having a poor outcome in terms of how they feel about their knee. So Lisham scores fell from 78 to 52 in non-operative cases. On the other hand, the patients who had surgery, they had good results. So similar studies out here, results out here. But most importantly, this is the kind of the crux of this argument. Like, most of the patients who did not have surgery are at an additional risk to having more tears, like meniscal tears or chondral injuries in the knee. So this is important. So if you do not do ACL reconstruction in a young child, they're at a higher risk of meniscal tears. And this kind of paper nailed the argument, and this is a relatively new paper that says that the irreparable meniscus tears are significantly more. So till date, a lot of community orthopedic surgeons or even some of my sports medicine colleagues will argue with me, or guys who do pediatric ACL reconstruction, as to what's the hurry, why do you need to do these surgeries? They're high risk surgeries. They are very young kids. You can damage the growth plates. All of the above is true, but we also should understand that they can have meniscus tears which cannot be repairable, and those are the single most important predictor of arthritis in the future if we cannot repair it in someone so young. So what are the options? Somewhere in between. So you start with maybe conservative treatment if it's an isolated ACL tear. If it's and you tell them that they won't be very happy. There are fair to poor results. You brace them. Most of them are not compliant, but that's still an option. That's a textbook answer. You won't be wrong if you inform the family about it. 99% of my patients and families, they choose surgery after I give them all the I have a 45-minute discussion sometimes with them about, hey, you don't have to do surgery kind of thing. By the end of it, they're like, can we opt for surgery? So all right, so what can you do? So when you come down to surgery, there are different options. Recently I saw a patient in Troy, and the family came with a huge binder and asked me about all these techniques. So they were like, do you do over the top technique? And I said, no, I don't do those. So sometimes the families and parents may be very informative about this. Most of them are Google MDs now. They look it up and things like that. So obviously, at the very least, even if you're not doing the techniques, you should be aware of those techniques. And she asked me a couple of other techniques which I didn't know. She was like, oh, do you know about this? I said, no, I don't. Never heard about it. So I don't know where she got that from. But so physis sparing, it's mainly intra-articular. You spare the growth plates on both sides, as you can see in that picture. Partial transphyseal is one of the most common ones I do in practice, because the most common age group that we see is that need a physis sparing technique is not the very young, but in somewhere in between. And then it's a complete transphyseal, which is more like a regular technique. So is it physis sparing? Is it so important? What happens if you go through the growth plate? So there are some not biomechanical, but radiological studies and animal studies that have been done. So say if you go through the growth plate, what's going to happen? So you will probably end up taking out around 8%. So if you go with a large reamer, you'll take out almost 8% of the physis. It's a 3D structure. It's a three-dimensional structure, so you'll end up taking out that much. So does that matter? So 8%. Just remember that number. And these studies are completely not related to these studies, which we'll discuss about animal studies here, where they kind of went through a growth plate with increasing diameter drills, and they noted that 7% of more would cause growth arrest. So somehow it really correlates with those other studies, and again, those are not related to these studies. So if you go with a larger diameter reamer, say 8 or a 9 or even a 10 in this young child, you might risk causing growth arrest. So if you go with a small diameter and go directly through the physis, that's fine. But then you'll have a smaller, and this is another study not related to the previous study, from a different place, from a different research group, and they came to the same conclusion. 79% of physis violation will cause no growth, but more than that will cause growth abnormalities. So at the very least, if you're going through the physis, go with a smaller reamer, and we should be fine, as long as it's again vertical. So however, even if you go through the physis, if you have the fixation on each side of the physis, it can cause tethering of that graft. And in this study, as I think it was done in dogs, and as the animal grew from with skeletal maturity, the graft failed. Almost all of the graft failed because of the stretching of the graft. So I kind of warn the families sometimes that yes, it incorporates and then it grows along with the knee, but it can stretch and it can be a little bit lax. So anyways, so conclusion from the animal and the radiographic studies is you have to kind of go with a smaller tunnel diameter. This is also asked sometimes in OIT. Straight vertical tunnel is better, and go medial with the tibial tunnel. So don't go too close to the tibial apophysis, the tibial tubercle apophysis, because that is a third growth plate which we don't talk about. But that also means smaller tunnels means smaller grafts, and vertical tibial tunnels are not anatomical. So that's a problem from going transphyseal. Now, like many sports, old-time sports surgeons, they swear by their trans-tibial vertical tunnels, and they say, we never had problems, we had excellent results. Similarly, there are a lot of sports guys who are like, we go through the physis all the time, we go vertical, we go smaller, and all the kids do great, which is understandable, but that's not anatomical. So let's talk about the different techniques, the biomechanics of different techniques. Which one is best biomechanically? So unfortunately, none of them are as good as the native ACL. That's understandable. But the over-the-top technique is pretty good. Sometimes it can be too tight, but it is pretty good in restoring biomechanical stability. So what they do is they kind of take a strip of the IT band and reroute it over the top of the condyle. So it's not anatomical. It's just or rerouting.
Do they use a staple on the condyle for the ITB?
Yeah. Initially, when they described, they did not use staples, but now they kind of reinforce with staple over there, go over the top, and then it is brought out on the tibial side below the intermeniscal ligament. So no tunnel on the tibial side as well. And then it just stitches to the periosteum. So no implants as such, no tunnels. So it is okay, but I fail to see how it can sustain over time. I think you'll have to have it.
Did you do these in fellowship?
No. I saw one kid who failed within a year. Her surgery was done at U of M, and I revised it actually. So that was an over-the-top technique, and it was like grossly loose. You could see it from a distance, and she used to, and it was done by a very good surgeon out there, but it failed within a year. But that's just one experience I have with that technique. But the guys who described this technique, they have kind of the largest series, 44 patients, and not that many, but still for pediatric ACL reconstruction is a pretty good number, and that excellent outcomes in 96% of the cases. So in their hands, it works. Maybe they do something which you probably don't know about, some secret ingredient kind of thing. So physis sparing, all-epiphyseal is the one that I prefer as well. And there are different types of technique, but this is the one that I do, and this is the one that's most popular. Basically, just go distal to the femoral growth plate, and on the tibial side, above the tibial growth plate. As you can see on the tibial side, it can be very challenging with drilling that tunnel. If you go too high, you blow out the cartilage in the top. If you go too low, you just scrape through the physis. So on the tibial side, it's much more challenging. On the femoral side, I don't go as close as that to the growth plate as described in this X-ray. I go a little bit more distal to that. There's one patient I went just like this because I thought this is the right technique, and that patient now has a 2 degree valgus because I think that the tunnel is too close to the growth plate and somehow interfering with that growth. So I'm watching that kid now. But anyway, so it's better to go a little bit distal and have peace of mind out there. So whichever you want to fix it, you can fix it. I use a different fixation, and they had great results. No leg length discrepancy, and this was kind of the pioneering technique for all-epiphyseal, and then there are several modifications. Children's Hospital of Philadelphia uses a intraop CT scan. It's pretty high tech, but obviously a lot of radiation, I guess, but it's low dose CT, but still. And then they use a retrodrill, and then that's what they do. So all this frenzy about sparing the growth plate stemmed from this one study, which is not even a study; it's just a survey. There are no large scale studies done to kind of answer this question: does going through the growth plate or doing a physis sparing ACL reconstruction really damage the growth plate? But this survey was done a long time back, and then there was no denominator. So these surgeons were asked, hey, did you have any leg length discrepancies, any complications? But they were not asked, how many have you done? Like out of 50, did you have one or two, or was it out of hundreds you had one? So we don't know. But many cases were like these. Obviously, if you have a hardware like that going through the growth plate, yes, you are bound to get some kind of complications. So and then there are bone plugs through the growth plate and things like that. So yes, that was kind of concerning, having leg length discrepancies. But as long as you don't have hardware through that, or bone plugs through that, you should be still okay if you go through the growth plate, I guess. So this is kind of an overview of the studies that were done. The flashing star is about something significant in that study. So for example, Ballin study, only 5 cases, 2 had re-tears. That's not good. Gebhardt study, 40 patients. That's a good number. But re-tears in 3, not bad. 44, that's one of the largest series that I came across. One patient, 5-degree valgus, asymptomatic. Now, 5-degree valgus is a pretty big thing in my mind, because remember, we sometimes do HTOs and osteotomies for even 2 or 3 degree of valgus. For total knees, we are concerned if the prosthesis is more than 3 or 4 degrees in varus or valgus. So it may not. Obviously, the patient will be asymptomatic now. The patient won't complain of pain if she has 5 degrees of valgus. But in the future, 40 years from now, maybe it might lead to arthritis or something. So I think that's significant. So, but
what's the youngest patient who's done an ACL for?
I have done 6 years.
6 year old.
Mm-hmm.
I would say that's like 7.4
Yeah.
years of age.
Yeah. Right. Exactly. So yeah, and the second youngest I've done is, I think, a 7-year-old. So yeah. So those are really challenging sometimes. But that said, again, and one of the classic dogma is like, well, these patients don't do great. They can't return back to sports. If you place a non-anatomical ACL graft, they're not going to do great. But that's not true, because all these studies show that most of the patients went back to their sport. So not only does it prevent irreparable meniscus tears, doing ACL reconstruction in the young population kind of helps them return back to all activities with minimal complications, as we saw in all these studies. Maybe a little bit, maybe some valgus, which I think is consequential, but when the patients do great regardless. So this is a review article, one of the last few slides. So what's the summary? So when do you do physis sparing surgeries? So as I said, somewhere in between. So you don't have to go crazy about physis sparing surgeries. If the patient is nearing skeletal maturity, yes, by all means, just go through the growth plate, and you should be reassured that it will not cause any growth plate abnormalities. As we know, go with a smaller tunnel, try to get a little bit of vertical, and you should be all right. Very young kids, it's hard to kind of go through the physis and not worry about any medical legal complications, right? If you go through the growth plate and God forbid something happens, then obviously you're in a limbo there. So say an 8-year-old, 10-year-old, I mean, how do you justify going through the physis? Although some studies again do show you can go and it won't cause much problems. So and then there are the in-between ones, the Tanner stage 2 and 3. Yes, you can go through the growth plate, but I do a partial physis sparing, which means through the tibia, I'll go through the growth plate because it's in the center of the tibia. It's a smaller one. You can go vertical with that tunnel, and that's fine. But on the femoral side, I'll go epiphyseal, so distal to the growth plate, and spare the physis. Because on the femoral side, you go at an angle, right? So if you go at an angle, if you go vertical, then you're non-anatomical, and if you go at an angle, you can scrape the whole physis. So you either avoid it or just go straight vertical, which is non-anatomical. So I go horizontal. Every patient is different. There have been some instances where I had if for example 14-year-old with completely different growth plate morphology, and in fact I don't know if I have it in this talk, but there are two 14-year-olds I did the same day ACL reconstruction. One was a physis sparing because it had wide open growth plates, the other one had completely like closed growth plates. So just the numerical age is not enough. Either you get those bone age or you do a quick Tanner staging preoperatively. Obviously it's odd to do it in the clinic. You can do it before the surgery. Alright, these are not very important slides. Just quickly we'll go through this. Complications kind of the same like you get in adults. Arthropibrosis is still very common, although you might think that these are kids and they might be kind of more active and they'll get over their stiffness pretty fast. But that said, overall incidence is around 10%, which is very similar to adults, so something to remember. Overall, overall partial tears, I wouldn't go through this. I'll just I know some of you might have read about this story that came in the papers recently about this group out of Boston who have made some more advancements in their research, and then they're very close to, at least in the animal model, inject some stem cells on a collagen and the ACL heals. So these guys are gonna put us out of business because all you need to do is, if you see someone with an ACL tear, take them through, or even in office, you inject this kind of propriety. They'll probably have a, you open up a pack, take this to spin their blood, get those stem cells, put them in the collagen, and just inject into the knee. Maybe it's still 20 years in the future, but then you don't have to do an ACL reconstruction, just repair it, or just anyway. So that's I guess the last slide. All-epiphyseal for Tanner stage 1. Yes, if you're familiar with over the top, you can do that. And these are typically, again, I don't go by numbers, but I would say below the age of 10 in boys and below the age of 8 in girls. It's kind of pretty obvious. Tanner stage 2 and 3 is partial transphyseal. That's what I prefer, and it's what's recommended. Tanner stage 4, you really don't need to worry about the growth plate.